So, very good afternoon, everyone. At the outset, I would like to thank the KSOS for this opportunity. And more importantly, I would like to thank all the audience who are still waiting here and checking the OPL for us. So, uh, this instruction course, so we were talking about the different shades of macula. So, macula is the most vital region for central vision. And hence, early diagnosis and treatment is very essential for maintaining the central vision. So, in this instruction course, rather than delving into each macular pathology one by one, we decided we'll take it at a single go. So, what we decided is we'll look at the clinical findings, such as the membrane over the maculas, the fluid at macula, the pigmentation, the hemorrhages at macula, and the hard exudates and yellow lesions that you see there. So, I'll be talking about fluid at the macula, blue as the ocean. So, when we talk about fluid at the macula, right? You, as a ophthalmologist, most of us can easily diagnose fluid at the macula. You can see that there's some fluid at the macula. This is an NFOS view. You need a cross-section view to actually identify where this fluid is located. So OCT helps us. And quite honestly, gone are the days when we say that OCT is like, no, it's a luxury. It is a very must needed as of now for an ophthalmologist. So when you look at an OCT, you can have the fluid at the below the retina, that is subretinal fluid, or you can have within the retina, that is the intraretinal fluid, or you can have a combination where you have intraretinal fluid as well as subretinal fluid. So let's look at these pathologies now. Now, if you see this patient is, you can see a fluid right here, the greenish lesion. This is a multicolor image. So when you see this greenish lesion in a multicolor image, that indicates that the lesion is elevated. So you have fluid over here, and this is the zoom view where you can see the fluid here, and you can see some lesion over here. So what do you do about this? Now let us look at the OCT. So if you run the OCT over here, you can see the schisis over here in the retina. And as you reach this lesion, you can see there's a break here. So you see such a condition, the treatment is not medical, it is purely surgical. This patient will require a surgical intervention. So there's no point of loitering over there. You have to refer it to a VR surgeon. Now, another case where you see the subretinal fluid, you see as a fluid as there in the macula. And when you do the OCT, you can see the just as you run the OCT, you can see the serous PED here, and you could see some amount of trace of fibrin there, and the choroid is thickened. So this is a case of central serous retinopathy. Now, what are the investigations that you want to do? You would like to get an autofluorescence. OCT is must required. You can do an OCT, especially in chronic CSRs. OCT is very important to diagnose CNVMs. You can get an FFA ICG to look the leak. And most important thing, when you see a central serous retinopathy, the treatment is medical only except for one condition, because what happens is the moment you see the fluid at macula, we forget to look at the disc, and you might have an optic disc pit there. And when you have optic disc pit, the treatment is surgical and not medical. The treatment usually is observation. You can use, there's no point of trying out non-steroidal anti-inflammatory drugs there because there's no inflammation there, right? So rather than giving NSAIDs, you can actually try dorsolamides, carbonic anhydrase inhibitors. Focal laser, after doing an FFA, if you see that the leak is away from the fovea, you can do focal laser. PDT, sadly, we don't have that anymore. If you have a central leak, you can try subthreshold lasers. And in certain cases, you can also try medical management such as eplerenone. But the only problem is when you start eplerenone, you have to have the patient monitored for hyperkalemia and electrolyte imbalance. Now, this is another case where you see multiple pockets of SRF over here, right? Now, this is the OCT. Now, as you see the OCT here, you can just see this over here. So this is if you see the RP over here, in central serous retinopathy, you could see a PED and the RP was completely flat. Whereas you can see the RP is not exactly flat. There is some amount of undulation there. And along with that, this sign over here, this is called as a Ballard. There's a basilar detachment, and you can see the multiple pockets of fluid there. Okay. So we did an FFA for this patient, and you can see the starry sky pattern. This is a case of VKH, where the investigation that you require is a color fundus picture and an FFA, and the treatments are usually systemic steroids and immunosuppressives. There's another case. There's a huge, large macular fluid over here. You get an OCT done for this patient. Now, at this point of time, you see a large, huge PD. The first thing that you might think, okay, fine, this is probably a case of central serous retinopathy. But as you see run through the scan, you will see this. The PD is okay, fine. This is serous still here, but this sign over here, that is a notching of notch PD. And when you see a notch PD and the flat PD, irregular PDs over there, then probably you're looking at a case of polypodal choroidal vasculopathy. So the investigation required a color fundus picture. You can do an OCTA where you can see the network in most of the cases, that is a branching vascular network and a small amount of polyp in some amount, if you do a manual segment. FFA ICG still remains the gold standard for PCV. The treatment is anti-VEGFs, and usually in such cases you require normal ranibizumab will not do well. You will have to go for the higher anti-VEGFs such as brolucizumab, aflibercept, or faricimab. Now, this is another kind of case that you very commonly see. This is one of my patients who had a branch retinal vein occlusion, had a neovascularization for which the laser was done. This patient again came with a recurrent retinal hemorrhage. So this is a branch retinal vein occlusion, and when you do the OCT, you can see the intraretinal fluid over there, CME over there. So whenever you see such cases, systemic evaluation is very important, that we all know that. But what happens is many times, again, like I said, when we look at the macula, we tend to disregard the disc. And you know, sometimes the cause for the retinal vein occlusion might not be systemic factor, but the local factors such as glaucoma. So get a color fundus picture. OCT definitely is important. OCT and FFA is actually required when there's not much macular edema and if you're suspecting a macular ischemia. So treatment for such conditions are anti-VEGFs, or you can, since these conditions are very notorious to having recurring CMEs, intraocular steroids such as dexamethasone implants are very useful, and the role for lasers are only when there's neovascularization. There's another case. You can see the diabetic patient, you can see a lot of hard exudate there. This is the OCT. And when you see the hard, you can see a lot of intraretinal fluid over here. You can see hard exudate clumps over there. So this case is required. This is basically a case of diabetic macular edema. Color fundus picture is very important. Do an OCTA if you're suspecting macular ischemia, and you also do the FFA. Treatment, when you see do an FFA, you can see leaking aneurysms. So gone are the days when you used to do grid lasers. If you see leaking aneurysms, you can do a focal laser to them. In such cases, the case that I showed you, where there's a lot of hard exudates threatening the fovea. So yes, you can do focal laser there. You can do give anti-VEGFs. Intraocular steroid is usually a preferred modality when you see such hard exudates. And there's another case. So in this case, you can see a fibrovascular PD there, subretinal fluid. This is intraretinal fluid, and there's some amount of subretinal hyperreflective material. This is basically a case of macular neovascularization. OCTA can be used to diagnose the network. FFA ICG can be done, and treatment is usually anti-VEGF. So the take-home message is, gone are the days when you have to totally rely on your clinical examination only. You will require the assistance of OCTA to get a cross-section of the pathology there. And yes, when for most of the cases, almost majority of your cases, you can diagnose on the basis of clinical examination and OCT. And there are certain cases where that is not enough, and you might have to rely on dye-based angiography or OCT angiography.